since we are running over time, and to be able to conclude our session on time, with your permission, I suggest that we merge the remaining two sessions, and there are three panelists for the case presentations. So I would basically request Dr. Rajesh Chawla to be on the dais, Dr. Suryakant, yeah, and Dr. Yash Zaveri. With your permission, I would request Dr. Yash Zaveri to make one case presentation. And I would like to first, introduce Dr. Suryakant, who is a professor, head Department of Respiratory Medicine, King George Medical University, Lucknow. Yeah. And he's a member Institute of Governing Body, AIMS, Patna. He's a member Executive Council, UP. Medical University, Saipai, Ottawa. He's a brand ambassador for COVID vaccination and national COVID expert. And we have Dr. Yash Zaveri, who is the head CCM and Emergency Medicine, Region C Health, Lucknow. He is the gold medalist in anesthesiology with 17 years vast experience in critical care medicine. He has been awarded Presidential Citation, Indian Society of Critical Care Medicine, consecutively for 4 years, from 15 to 18, and is a keen researcher in CCM and credited with 30 books, chapters, and more than 40 original articles. What I would suggest that we would also basically invite doctors Alok Agarwal to be on the dais, Dr. Rajesh Rajput, Sandeep Mishra, Dr. Sandeep Mishra, Dr. Sandeep Mishra actually has come. Can you see if he's outside? Dr. Sandeep Mishra, Dr. Altamash. Altamash, is he joining us on the... Hello? Swati? No? Yeah, so he is joining on Zoom. And basically, after one case presentation, we will briefly discuss about the long haul COVID, that are the late complications of COVID. So, thank you very much, and I leave it to Dr. Yash Zaveri.
Thank you, Mr. Joshi. At the onset, I'd like to thank Dr. K.K. Agarwal family and Eris Life Sciences to have me here. We all cherish fond memories from Dr. K.K. Agarwal. We all paid homage to him. My first connection with Sir was during my internship when he came to Chennai for an inter-college quiz competition with Dr. Narottam Puri. And then later on, many years in Delhi, Hospitalised village, we have been interacting. And he has been inspiration during COVID also to start online teaching and education and how to reach to masses. That was the probably USP from Dr. K.K. Agarwal. Can you please display my presentation? Yeah. Okay. So the title is Bad COVID Cases. Bad COVID cases, hospitalized, managed, recovered. Good times become good memories and bad times become good lessons. So the outcomes might be bad or good, that does not matter. But what you do in the due course of treatment is most important. Your intent and your line of treatment should always be good. No conflict of interest to declare. The learning objectives from this case, we have to be contextual. What we practice in a tertiary care center might not work in a community healthcare center. In your same setting, you should know what are the limitations of your manpower during day or night, and you have to work accordingly. Evidence is dynamic, especially in COVID, so we have to update ourselves. COVID is a great mimicker, not only in presentation, but also in long haul. Infectious disease differentials always remain, especially in Indian perspective. Treat the patients, not the numbers, especially if we talk about the D-dimer, IL-6, and we were always perplexed with all these big numbers. The biggest lesson from COVID for all of us is invest in infection control prevention. An ounce of prevention is better than a pound of cure. Medico-legal issues and documentation. However bad the situation is, whatever best intent you put into patient care, if something goes wrong, patient will have no sympathy for you. So always document what you do. We had this patient on 9th of May. He was in fact admitted through Sonu Sood charity to us. He was a singer in Bollywood. He was admitted with severe breathlessness for 20 days, progressive weakness for 20 days. He was moderately malnourished at time of admission. So we admitted him in the ICU. He was on high oxygen support while he was admitted. What does this high oxygen support means? It has no context. Above 15 liters of oxygen if we use, we all have understood it goes waste. And the amount of oxygen which goes waste above putting flows above 15 liters is tremendous. So we have to always remember supraphysiological targets, supraphysiological doses of any drug does not work. This is the lesson number 1 from this case. So the patient was directly admitted to COVID ICU. Patient was initially started with steroids, oxygen supplementation, low molecular weight heparin, and other supportive therapies. Patient was given oxygen support with different devices as was clinically required. At times, patient has to eat, so his BiPAP was removed. At times, patient was on high-flow nasal oxygen, and his high oxygen requirement was very, very fluctuant. I'll show you in details. One day it was 15 liters, other day it was 4 liters, so it always perplexed us. Screening clinical specimens were sent for cultures. His RT-PCR 2 days before his admission was negative at another hospital. All the relevant investigations were sent, so he was treated as presumptive COVID. So, again, the lesson here is use what works. If you are not comfortable with a particular device or a particular drug, do not jump to use that drug. Use what you are best trained to use and what's available to you. Especially the debate was between NIV and HFNC those days. The jury was still out. We were also confused. So whenever the oxygen requirement was very, very high, work of breathing was high, CO2 levels were high, we tried to use NIV as against patients whose work of breathing was not excessively high, or if CO2 was normal, then we use HFNC. So it was mix and match all the time. We have to also remember there are best case scenarios which we always read in our textbooks and journals, which generally does not apply to the routine practice, the real world. So we have to look at the real world scenarios as against these best case scenarios. And when the pandemic was peaking, we were probably in the worst case scenario. The patient did not consent for intubation, despite on third day patient was very tachypneic and he would have been intubated otherwise in the routine circumstances. His oxygen requirement was 15 liters per minute with an NRBM, SpO2 was about 80%. He was on NIV plus ventilator, NIV on ventilator with an FiO2 of 1 and he was prone. Work of breathing reduced a bit, say his respiratory rate come down from 38 to 25 to 28, but again it was transient. HRCT on 10th was scoring 38 out of 40. On 10th, his oxygen requirement decreased to 6 liters, simple face mask, SpO2 93%. 11th, it was again 5 liters. Consent and documentation is must. Why I am again and again emphasizing on this? We did everything for this patient. The cost was also quite brought down drastically, and the whole team was behind this patient. But after the discharge, the patient gave very, very bad reviews about the hospital. People were not shifting out of the ICUs, but he had 2 or 3 serious life-threatening episodes during admission. That is why he was not shifted, which were very well documented in the records and video recorded also. Use what works. The guidelines have to be contextual. We have to also do oxygen rationing, especially when we are in crisis, when oxygen wasn't short. Triaging. Triaging becomes very, very important, especially in pandemic times or when our resources are overwhelmed. We have to look at the patient, what level of care the patient requires, which patients require admission. At times, there were patients who were very resourceful. They were queuing up for admission. 1 or 2 liters of oxygen, they wanted to be in oxygen because it's a safe place. So we have to be very, very ethical in triaging also. Prime non-noster, whatever you do no harm to the patient, especially in context to newer intervention and newer drugs. Everybody started using drugs which they have never used. Otherwise, these patients should have been referred to the right specialist for using such drugs. Diagnostic workup always have to be thorough, whether pandemic times, whether you are overwhelmed or not. Always have an open-minded approach, streamlined framework for research and development during your work. So this is the oxygen requirement. You can see it is so fluctuant. One day it was high, one day it was low. So we have no trend of oxygen requirement actually. And what was working, we were not sure at all. He had an episode of septic shock on 19th May. Antibiotics were escalated and sepsis workup was done again as a new onset sepsis. 20th of May, we did an HRCT, which showed diffuse ground glass opacity, interstitial septic thickening, crazy pavement, and there was some fibrosis also. His CT severity score at this point was 25 out of 25, and he has mild pneumomediastinum also. Now we were in a fix whether to use NIV. Patient has not consented for intubation, the family. New onset sepsis, always do a fresh workup. However critical the patient is, if the patient has new onset sepsis in the hospital, always do a fresh new workup. Common things are common. Gram-negative infections are much commoner than rarer infections. However, if you have a host which is immunocompromised, as was this patient, you need to do a detailed workup from infection control point of view. Threshold for HRCT, this is what I learned during COVID pandemic. As an intensivist, I had a very, very high threshold for HRCT, and generally we used to work with X-rays most of the time. But during this pandemic, we realized if a patient has pneumonia, our threshold for HRCT should not be very high. This was the hospital course. His stool occult blood was positive on 21 of May. NORAD was tapered till 24th of May. 24th May onwards, he had diarrhea, 4 loose stools, and his oxygen requirement was 5 liters at this point. He was shifted to isolation cubicle in the COVID ICU on 26th, a day after his diarrhea started, on suspicion of Clostridium. There was some bleeding per rectum, so Eliquis, which was on, was stopped. Diarrhea continued till 26th and 27th. 28th, patient blood management, tranexamic acid and vitamin K, everything was started. What I want to highlight here, patient was on steroids, patient was on antibiotic, patient was moderately cachexic, patient was not eating well. So he had houseful for induction of stress ulcers. This was Clostridium, it was steroids, patient was on antifibrotics. What was contributing to these ulcers and bleeding was still a suspense for us. Diarrhea could persist in some of the COVID patients for a much, much longer duration. It is seen in long COVID also, so that was also in one of the differentials. Anyhow, we have sent Clostridium difficile toxin assay for this patient and started on oral vancomycin. Hospital course, colonoscopy was planned and it revealed large, irregular shaped multiple ulcers with overlying slough causing a pseudomembrane-like structure. Biopsy was also done, oral vancomycin was started. Upper GI endoscopy was not consented. His SpO2 fall down to 80% during colonoscopy. So we were also not very keen to push for upper GI endoscopy that he might require intubation. He had an episode of critical GI bleed on 28th May. Lower GI endoscopy I already told, bleeding continued and more blood products were required. Overall, he was treated on lines of pseudomembranous colitis at this point. These are the D-dimer levels. You can see most of the time it was well below 200. However, one value was up to 557. We treated this patient with low molecular weight heparin as we would have done for any critically ill patient. After a few days, we shifted the patient to apriximab, and once there was GI bleed and stool occult blood was positive, we stopped it totally. CRP values were 58 to 27.5. We did a homocysteine level also. It was 11. C. difficile toxin assay came positive. after 2 days. So treat the patient, not the numbers. Again, this is a very, very important lesson. When you think you are right, even when you are wrong. We actually don't know many a times, especially in ICU. There is too much of clinical data, there is too much of lab data, there are diverse opinions. So work with the clinical diagnosis and work on it. That is very, very important. You have to follow the principle of parsimony. Do not have 10 diagnoses in your mind. You have 2 or 3 differences, and the top one you work on with. You have to take this KISS approach, keep it simple. Pragmatic approach and open-minded approach. Try to incorporate your teammates' view. That is what team is all about. I also learned the new definition of ICU. ICU is nothing but a team. So the most important component of definition of ICU is team. And we have to be very, very appreciative of each and every opinion from the team members. So the patient was ultimately discharged on 30th of May with this diagnosis of presumptive bilateral COVID pneumonia because all through his stay and before his RT-PCR was negative. Septic shock, pneumomediastinum, GI bleed, anal fissure, pseudomembranous colitis. Thank you.
Thank you.
Thank you, sir.
Thank you. Can I request all the panelists to please come on the dais? Since there is a time shortage, so we'll combine these 2 sessions. And first I will discuss, please Rajiv come. So first we'll discuss about little bit about the acute care since Dr. Yash has talked about, and then we'll have a small case presentation by Dr. Rajiv, and then we'll discuss about the long haul. And if I think everyone has agreed because we want to finish it by 9 p.m. So you see, like Dr. Yash presented, we have been managing these acute cases, and the basic principle of managing critical care medicine didn't change. It was the no knowledge about how to treat this patient which kept on changing, steroid, baricitinib, remdesivir, steroid. So this was creating a lot of confusion. This was one aspect, and now after 2 years we've come to conclusion, probably it is the timing. Very, very important when to give a particular medicine. Because if you delay, then it doesn't help. That's what we realize all through this. And the people now, the survival is more because the timing has really changed. And not allowing a patient who is desaturating at home. Now, at least in this situation, please don't advise your patients and that they should not treat, because everybody has an oximeter at home and they keep on coming late, and then it is difficult. So they should be now, because it's not that pandemic, they should be in hospital if anybody gets COVID. Other thing is that all these hypoxemic patients only should be given steroids. A patient who doesn't require oxygen should not be given steroid. So this is also sorted. Remdesivir can be given in these patients, and if a person is a high risk, if he can afford monoclonal antibodies, which is a cocktail of 2 drugs which is available, should be given, and we are giving it. So this is all also sorted. Recently a new drug has come in which has shown a good promise, that's a baricitinib. And they have shown, people have given for a long time, and they have also shown promise with this drug. So basically these drugs which have found some role. As far as the critical care is concerned, oxygen, of course, but this giving 15 liters on a high flow oxygen for a long time has caused a lot of harm. I feel because you give almost 90% of oxygen, and it does contribute to some kind of fibrosis. Then the role of non-invasive ventilation and HFNAC. Any can be given, but you should not delay too much of ventilation, because your infection control practices should be improved, because if you delay intubation, I have seen these patients don't do well. They don't do well on prone positioning, or I have done people on a very 2 months of ECMO, they don't do well if you do not intubate also at appropriate time. So they should be in a specialized center, and they need to be intubated. Do not continue on a 90% oxygen on HFNAC or NIV, because people only survive if you don't ventilate. Please get this idea out of your mind. Because we've seen the people who were ventilated, when they were not maintaining on these or requiring 90% or 80%, they should be ventilated. And the rest of the treatment, low tidal volume strategy, everything remains same. So I'll ask Dr. Suryakant, before we go to long haul, what is his opinion about managing these patients?
First of all, I want to congratulate Dr. Yash for a very challenging case, especially in a corporate setting. I belong to a government setup, but I feel that in government setup, you have a lot of umbrellas to protect yourself. In corporate setting, when one is paying heavily, if he is paying heavily, he is asking too many questions. So it was a really challenging case for you, because you managed initially, of course, it was a presumptive COVID, and as we know, the management of presumptive COVID is as the COVID, because 30% chances are that yet RT-PCR can be negative. Sensitivity is only 70%. The second thing was the course of the management process. If you just see in the last PPT, which you summarized, Dr. Yash, beautifully, that you see there is always a double-edged sword, Dr. Chabla. Whatever you give, if you give oxygen, you said yes, there is a chances for a lot of fibrosis and a lot of other complications. If you give high pressure NIV, then of course there are 10 to 13% chances of pneumomediastinum and pneumothorax as your patient faced. So, and of course, the coincidentally or unfortunately or by complication or by thing, the bleeding per rectum. It's a serious complication. Bleeding anywhere from any part of the body is a serious complication. And of course, to manage a patient who is bleeding heavily from any source, and of course, a lot of vasopressors you gave, and then of course, the patient could be survived. So I think that yes, Dr. Rajesh Chabla, you are right, that one should remember that the first is the judicious use of steroid and judicious use of oxygen. The problem is that the whole world is propagating that only two things are working, only two magics are working. One magic is oxygen and second magic is steroid. But problem is that how to use judiciously. Yes, they are doing wonderful job. They have done wonderful job in first wave also and second wave also, but they should be used judiciously. If patient oxygen saturation is above 94, you must not give steroid. That's one message. Because it's a mild COVID, and of course mild COVID, they are still in phase of viremia. So if you are giving at this stage of steroid, you may increase the viral load. The second of judicious use of the steroid, of course, oxygen. Then of course what happens usually in government hospital, of course you are doing rationing of the oxygen, but in government hospital what happens when they are hospitalized and oxygen ka wo regulator बढ़ा के, everybody want that my oxygen should go 99, 100, and that is very problematic. So I think we have to propagate our fraternity and community also that yes, please don't keep oxygen saturation above 92 or 93 or 94. It's harmful. The third thing, as you mentioned, the HFNC versus NIB, again, is a very debatable thing, but yes, if CO2 retention is there, you can use NIB on priority basis, hypoxemia is there, but for a long-term high flow oxygen, Dr. Chabla, I am very much agree with you that long-term high flow oxygen use is not a good practice. So thank you very much.
You know, another very important thing, Rajesh, I'm going to ask you. See, I think all of you sitting here struggled with diabetes. People who are not known, they had a very high sugar for a long time, and people who had diabetes, very difficult to control. So what is your advice on this?
Well, although we are already a second world highest capital having number of people with diabetes, but you are right, large number of people are newly diagnosed during COVID infection. And there are many theories for that. We will not go into those details, including direct toxic damage to pancreas, to ACE receptor expression over there. But then problem is aggravated by two things. One, there is a cytokine storm which is happening. Number two, high doses of steroid. And it is not only timing, it is dose also. Although the recommendations are there to use how many doses of steroid. Recovery trial has used only 6 milligram a day. But we have seen people using 8 milligram twice in a day, dexamethasone, which is a very high dose. People are using 250 milligram of methylprednisolone for 5 days or 7 days. So the problem is compounded by our genetic background, predisposition for diabetes, injudiciously very high doses of steroids which are used for a prolonged period of time, and then over and above cytokine milieu. And definitely it has made diabetes a difficult, challenging problem. But what we have done at our institutes, probably in all these patients who are admitted in ICU setups, basal bolus insulin regime is the best regime. We have to utilize basal bolus insulin regime. Unfortunately, in most of the hospital, I am also working in a government institute hospital, most of the other places, people are not very much comfortable with basal bolus insulin regime. They still are utilizing in India sliding scale insulin regime and do not give proper cover with basal insulinization. The result is there are spikes of hypers and hypos, and that is what problems is often coming to us. That morning we have seen sugar of 360, evening the sugar is 80. So these are the challenges. So to overcome these challenges, what we advocate, all the hospitals, whether they are private hospitals, whether they are government hospitals, they should give ready-made charts and instructions to nursing staff and to the critical care staff which is working there. That if patient is coming there with diabetes, uncontrolled sugar, you have to put patient on basal bolus insulin therapy. And then obviously based on the sugar profile, we can titrate the dosage of all the insulins. But then with steroid, definitely it is going to be a challenge. Another very important thing which has come up in COVID is use of metformin. Until and unless patient has uremia, serum creatinine are on the higher side with eGFR less than 30 ml, or patient has hepatic derangement, because that is again a very important issue during COVID times. Otherwise, all patients should be given a metformin, because metformin is the only drug which is going to not only reduce your insulin resistance, going to make insulin work better, which you are giving exogenously. Also, I do not know how many of us know, actually metformin was initially developed as an anti-influenza drug. And later on, actually, its hyperglycemic efficacy was realized and it was developed as a diabetic medication. So metformin also acts through number of other pathways where it is useful. And if we see all the meta-analysis of all the drugs, it is metformin which is found to be the best medication. And again, metformin is highly underutilized during COVID pandemic all over the countries. So we always advocate that start metformin, except only in those situations where patients are not, or it is contraindicated, like I have told you, renal failure or liver failure. So these are few of the important messages that are important. And the biggest challenge, again I will stop because otherwise we'll, that we have to follow one protocol. Unfortunately, whatever protocol you are comfortable with in your hospital, the staff should follow that protocol seriously and should adhere to it. It should not happen that I am today on the duty, tomorrow Dr. Yash came and he will start something different. So the patient sugars are not going
He will not.
Thank you.
Okay, no, I am going to ask a very important, which I felt all through the management of COVID patient to Dr. Sandeep Mishra, who is a cardiologist, that, tachycardia, which we found that most of the patient had a tachycardia and it persisted. And some of the patients, even after 2 months, the tachycardia is persisting. We have not done cardiac MRI. There was a report from All India Institute that they noticed endotheliitis, and which is probably the reason. So what's your view on this?
So I think it's a very good question, and I would say that actually COVID is a three-phase disease, and people generally think it of as two-phase disease. So I think first phase is viremia, where a lot of infection is there because of virus. So it's a virus infection. then once the virus infection, comes, then there is a start of inflammatory and antibody response by the body. So it's a defense mechanism that gets activated, which includes the inflammatory markers and interleukins and all those things. And that phase is generally focused on either lungs, mostly on lungs, but also on heart and kidneys. And that phase lasts for about, let us say, 7 days or about 10 days. And then starts the third phase. And by that time, because lung infection improves, and so people are getting discharged, and they go home and they think they are cured of COVID disease. But this is the start of third phase. And that third phase is that some of the inflammatory things come down, but a lot of inflammatory markers are still persisting. And, I don't know whether you have read, there is, activation of mast cells, and histamines are released. And I think that low phase of inflammation, which persists for another 3 to 6 months. And that is the reason why there is a vasculitis kind of thing. And that vasculitis kind of thing and myocarditis kind of, thing, but particularly vasculitis kind of thing, which is subclinical, and that leads to this response, tachycardia, etc. And interestingly, that persists for another 3 to 6 months. And because of that vasculitis thing, you hear that person got discharged, and week later, 2 weeks later, got heart attack and has come back. This is because there is a persisting inflammation in the vessels, and which makes it more thrombogenic, very easy to get the thrombus formed. And D-dimer is something which you can keep monitoring and can help you there. But it is not only D-dimer, but there are so many other inflammatory markers which are increased. Some of them we don't know at all actually, but they persist for 3 to 6 months. And I think that is the thing. And you have seen that people go to gym and they start gymming after 1 month, thinking that they are cured of COVID, and they suffer sudden cardiac death. So, what I want to bring to your notice is this third phase. I don't call it post-COVID. I call it actually third phase of COVID, which is this persisting inflammatory, response, which may go as long as 6 months. So
in continuation of this, may I now invite Dr. Rajiv Anand, who is very restless. So he's going to present a case of long COVID, and on that we will take all the questions related to that, following that. Please, Dr. Rajiv. Inka slide laga.
If you allow me, I can just add one small bit that, you might say that there is a lot of tachycardia, there is a lot of fatigue, there is lack of sleep, etc. And the treatment is famotidine, very interestingly, because it is a histamine receptor blocker. If it is a very serious case, you have to add cetirizine as well. But famotidine, the top dose is 80 mg TID, but lower dose could be 40 BD, something like that. So
Ivabradine has been used rampantly all over.
Ivabradine does not act on histamine at all. So you have to block the histaminic receptors in this post-COVID situation.
So what should be the minimum dose safely can be given?
For famotidine, 40 mg BD or 40 mg OD even.
Rajiv is a very eminent neurologist. We are friends for a very long time. So he's going to present it.
Thank you, Rajesh. I'm not restless per se, but this is an exciting evening and a very important evening where we are together because of one person. Even if we have not known him personally, he was an open lighthouse, I'll say. So it's an open house where our source of light is Dr. K.K. Agarwal. And I also thank Aris Life Sciences to have brought us together here. It's a unique evening and probably my first evening after 23rd of March where we are gathered like this. Otherwise, it was Zoom only. I'm not going to present a case, but probably whatever has been talked about, can you start my slideshow? Whatever has been talked actually is there in my slides, which I didn't know what was being talked. So it will be a befitting summary of whatever we have talked. Only thing what I have learned is it's my knowledge about anything which makes me aware of my ignorance. So similarly, it's our present day knowledge of COVID tells us that we have yet to gain supremacy over COVID. COVID still is supreme today. Whatever we learnt on day one became redundant subsequently. So similarly, whatever we have known till today, our experts are telling us we have to judiciously apply to it. It has been a tremendous, next slide, tough year for whole of the civilization, human being in many ways. And it is definitely, I believe, one of my colleagues was telling that people will forget it. But I don't think it will allow people to forget it. The second wave which came to Delhi and probably to whole of the country at different times and probably to whole of the world is not going to allow us to forget it. It entered homes, it entered everywhere, it entered, you can be most privileged and most underprivileged, and it probably is an equalizer, whatever it is doing. And even the knowledge, what you gain, makes you aware of your lack of knowledge. It is the knowledge, it's not the... So it is making us humble that we know very little about it. And I also agree with Rajesh when he said that we have by and large controlled it, but one surprise can be a variation. So variant, new variant coming up. So that's another issue which confronts us. But in any way, I'm thankful to Aris and KK for having given us an opportunity. Even though I was not a very close associate personally, but I am in the Delhi, and we met on many occasions, and you almost need and that endless zeal to learn and disseminate knowledge to actually win over COVID, even today, though it is almost 1.5 years. But any day can be beginning. Today there is, like we were saying, less than 50 cases we are having, but today it is 55. So it sends an alarm bell that there is 20% hike than yesterday. So we have not gotten over COVID as yet. That's one thing I know of. And this is what was one of the questions, how is COVID pandemic? We have dwelled over it, and I feel it has affected everybody. And effect is continuous. That is what long haul is. If not physically, we were talking about tachycardia, I'll comment about that also. If not physically, it's emotionally, financially, socially, in every way it is challenging. In some way, we doctors were fortunate that we never had to stop and jailed. People were virtually living in jails. Right from 23rd March onwards, me and Dr. Chawla work in similar circumstances. So we were on the job. So we never felt that sense of being jailed, but we were also threatened by getting infected. Most of us actually got it. Either your family member got first or other person got first. And so this is what COVID did to all of us. Everybody can have stories. Next slide. So this is, it's not a case presentation, but this is the presentation. So it didn't break the system, it exposed the broken system, which is still broken today. So that's what the job which is left, and that's what the job all of us to take. So one of the legal experts who was here was telling me, doctor, don't bother about other things. But it's high time, like KK took a lead as a leader, doctors should also assert themselves in public policies so that those policies are people-friendly. Most of the time, people are not going to listen to you. People are not going to give you what you need for patient to be cared of. Infrastructures are not there. And the whole blame comes on the medical community. That act is passed by. There were draconian orders throughout the pandemic. Draconian orders against the doctor by the magistrates or whatever the powers may be. So we need to work upon that, and that is also going to be helpful to you and your patients. Otherwise, medical science per se may survive, but the practice of medicine will not survive until unless we become stronger to help our patient. Next slide. So I hope the lesson will really be that we can't afford as a society to create the fire brigade once the house is on fire, we need the fire brigade ready all the time, hoping that it never has to be deployed. So this is what is needed. Otherwise, we are not prepared even today. We increase the number of beds, we increase the oxygen, we increase everything. But this is just first aid. It is not the treatment of COVID, because we don't know the treatment of COVID. We don't know how to attack this virus and eliminate this virus. We are all saying we are living under the fear that it might come back again. So we know the first aid, and even for that first aid, we do not have the resources when it overwhelms us. No country can have it, but we were particularly unfortunate to be blamed for it also, whereas it is not our fault. Next slide. So this is what long COVID is. Even if the virus is out of your body, this is how people are. Next slide. So somebody was alluding to first wave, first, second and third part of the COVID. So COVID definitely has an acute phase. Then there is a persistent of some symptoms for longer period of time, up to 4 weeks in the same patient, which may be continuous inflammatory phenomena. And then there are symptoms which are beyond 12 weeks, which is called long COVID. There may be different explanation. However, you all know, you all have experienced what we learned in the first wave about the patients, how to treat them, was not applicable in the second phase. In the first phase, you had days, patient will have symptoms, then you knew that 7 days, 10 days, if it is over, patient was safe. But the second wave, my critical care people will know, and they know it better, that we could not predict when it is safe. Just now we have said that the patient may have sudden cardiac arrest. We have had patient. So I always used to say, Dr. K.K. Agarwal, Dr. Shekhar Agarwal, they knew what is the best treatment. They got the best treatment, but the COVID won. So therefore I say that whatever principles we have learned are not complete. They are still incomplete. In fact, I feel that there is a continuous immunoinflammatory coagulopathy which affects whole of the vascular system, be it brain, be it kidney. In front of your own eyes, patient having received the steroids at the right time, patient having received remdesivir at the right time, patient having received tocilizumab at the right time, patient is in the best of the institute in this country. What went wrong? Because we don't know completely what to do at that stage. These people, almost all of you, I as a neurologist know my stroke patient, despite full dose of anticoagulation, and are having a ischemic infarct and a hemorrhage simultaneously. What to do? So we don't know. There are many more things to learn. In fact, today, after acute COVID has subsided, we are seeing patients which are challenging us. So there are more things to be learned today. It has to be continuous process. It's a teacher's day tomorrow. All of the best teacher in us will come out when we continue to remain students. Even in this evening, when I have heard to my colleagues, I have picked up few points. How to carry myself as an individual in the society and how to learn medicine. And then in the end, I was scared that how to practice it safely tomorrow. So these are the challenges which are going to haunt us. I'm not going to talk a lot of theory about how to do it because it's going to take probably many days of symposia to discuss just one topic. So I summarize, it's an immunoinflammatory coagulopathy where you try to treat immunity part with steroids. You're treating coagulopathy part with anticoagulants, but still your patient worsens. So we do not know what is the causation. You must have had, I could have shown you pictures. My one stroke, person is doing endovascular embolectomy. People have done PTCA and simultaneously during their procedure, the clot is reforming. In the same artery, the clot is reforming. So we still do not know the total mechanism. In some patient it works. Ultimately, there are some patient-specific mechanism. Maybe we'll know them better. So next slide. So what we were talking about and what we are going to be confronting is, since the millions of people have got COVID, so now most of us are going to see patients who have got lingering symptoms. In fact, initially, we call them psychological symptoms. One of the doctor whom I know works in a government organization. Post-COVID, she was not feeling well, and her boss was issuing a letter that why don't you join? She used to say that I don't have energy, I feel breathless, I feel fatigue. So these are now we know is a reality. So we are going to confront lot of patients. In fact, in some countries, and Rajesh may be a pointer, we may have to have COVID clinics, post-COVID clinics, where we give them multidisciplinary help to manage their life after post-COVID. Some of them are physical symptoms, but more than physical, there may be emotional and other issues. Next slide. So these are from So it's an umbrella term. So that umbrella term may mean post-long haul COVID, which has now been defined, but I still feel nothing is well defined about COVID as yet. Next slide. So this is sometimes many patients come to me. So I feel I have a dementia. In fact, what is happening is forgetfulness. So people who already had mild dementia became agitated, became more worse, and people who never had, even young doctors are coming and telling me that it is happening like that. Next slide. So, next slide. So what I want to stress is a lot of people are having psychological problems. First, next. So next. So I've been told next. So next. So this is what the summary, in fact, what I have been listening to many podcasts, we have seen each and every system being affected during acute phase of COVID, which is known as para-infectious syndrome, like you have nerves involvement, you have spinal cord involvement, you have brain involvement, and post-infection also. Post-COVID we are seeing, since the time doesn't allow, but we should be cautious that these things are happening to our patients of COVID. Our war with COVID is not over. We have now a lot of people say veterans coming out. So those who have recovered COVID are veterans, but they are also still ravaged. Next slide. So this is what we wish, that everybody should be happy, everybody should be safe, and everybody should be enjoying a good health. Next slide. So prepare for the worst and hope the best. Be safe. Next slide. So this is the article which I just want to give a reference to. This is free article. It gives you everything about neurology in COVID, so you can download it. You can hear a podcast. Next. So this is my last slide. So we must thank COVID for having taught us, because this is tomorrow we are going to say, so this is for tomorrow morning. So Teachers of the Year award goes to COVID-19, taught us what life is about: simplicity, spirituality, and plus uncertainty. Thank you very much. Thank you.
Thank you, Rajiv. Can I request all the panelists to come on the dais, please? Dr. Sandeep, Dr. Suryakant, Dr. Rajesh is already there. So before I ask you, we have Dr. Altamash Sheikh, who is on Zoom. He's a diabetologist working in Mumbai. So is he there? Can I ask him? Okay, he's not available. So, you know, lot of problems, I think the people, I will ask each one of them, because the problems which patients are coming, and all of you also must be facing. Any one of you wants to ask any questions and want to discuss or give his comment is most welcome. So let me start from Rajiv only. You know, a lot of patients are complaining that they are feeling weak. And this is a very, very common complaint. I have my friend sitting, Dr. Umesh Mittal. So he will also say that a lot of people, so what is the reason and what should be done?
We do not have guidelines to investigate long haul COVID, but definitely, as I told you, passing reference, one of my doctor junior, was having these symptoms, so these are genuine symptoms, don't pass them as psycho. So this is what we learned, we were, as a clinician, if I am not a psychiatrist, we were focused on hardcore symptoms. So these are true symptoms, try to help your patient. And what to do is, what I read and what I heard all over, and what I do with my patient, ask them to improve their lifestyle and start with light yoga, breathing exercise so that their energy level comes back, but it is a genuine symptom. And without your asking, I want to tell about tachycardia also. It's a neurological symptom post-COVID because of definite autonomic neuropathy involvement, and port syndrome also becomes more common. So there are symptoms, and those are genuine symptoms, and those should be taken care of. What I do is, as one of my colleagues suggested, so I do the inflammatory marker again if the symptoms are very persistent. We do not have any data, but the best expert in the field says that sometimes if there is a persistent inflammation, a very low dosage of steroids may work, but you have to be very specific. You have to see that you are not harming the patient. So these patients have to be re-investigated. And another thing which our colleague in critical care medicine told, that in ICU you recheck whether you are missing anything. So your patient may be having some other new problem also coming up that also needs to be investigated. So patient should be taken seriously. Full history, clinical examination and then relevant investigation will solve the issue.
Dr.
Right.
Rajesh.
Just to add, weakness after post-COVID, from endocrinologist perspective, three very important things to be kept in mind. Patients, as I've told you, are given very high doses of steroid and for a very prolonged period of time. So you might have actually induced hypothalamo-pituitary adrenal axis suppression. Now when you withdraw all of a sudden these high doses of steroid, patients actually started feeling weak for some days. So we have to understand, but we have actually done harm to the patient instead of, so there for some time low dose of steroid might help. Second, post-COVID, it's a viral illness. There are reports, and we have published our own consensus statement from Indian Thyroid Society, that there are cases of viral thyroiditis. And with viral thyroiditis, there is an unrecognized thyrotoxic phase, during which patient will lose weight, patient will feel weak. All these things are going to happen. And most of the time, this phase goes unrecognized. And this is associated with increase in ESR, increase in CRP. So unfortunately, if we are relying only on inflammatory marker and measuring CRP, CRP will be found to be high and we will be wrongly labeling that COVID has again come back. Third very important thing, there is, and we have started this study, new onset diabetes after COVID. Like there is a term, NODAT, new onset diabetes after transplantation. Now we have new onset diabetes after COVID. So these are the three very important things from endocrinologist perspective whenever patients are coming to you with unexplained weakness for which we actually look into it. And if obviously we are not finding it, then there are many other causes as we have discussed. But then there are a number of causes. So this is from my...
Just one, if you allow me. So I have seen that incidence of Guillain-Barré syndrome also coming up with weakness.
Yeah,
so
that's
as he says, and we all stress that you be very patient, listen to your patient and get him investigated.
Dr. Alok, what are the ENT problems the people are coming post-COVID to you? And how to manage them also?
Yes. So, first of all, the people are coming with loss of smell, which was supposed to be the first sign and symptoms. But after the COVID, loss of smell or altered sense of smell. They are feeling that something which is putrid is coming out from the nose. They don't feel taste. They don't feel like eating. So, we have noticed in very many patients that there is some degeneration of the sustentacular cells of the nasal mucosa, which is causing the harm to the olfactory system. And in these patients, local intranasal corticosteroids or sometimes a mild dose of the systemic corticosteroids works, or if anything doesn't work, then we emphasize on retraining of the smelling system, like smelling the eucalyptus oil or rosy smell or coffee or something like that, at least 4 times a day, right? And the second thing, which is as far as the ENT point of view is concerned, as Dr. have already explained, that thyroiditis, we have also seen the patients during the COVID time also, that the patients were complaining of pain in the neck. And we got this test done of the thyroid hormone test and anti-thyroid antibodies, and they found that these patients were having the thyroiditis. And we have given them again the anti-inflammatory treatment in the form of some anti-inflammatory therapy, and it worked very well. Third thing which has come as a long haul as a COVID, as you people already know, is black fungus or mucormycosis. It has come very evidently, I don't know why, in India, and we have lost so many of patients because of this mucormycosis. And we still don't know why the people were affected so much in our country, not in other countries, as this COVID affected other countries and people in other countries also. But in our country, particularly in Delhi also, a lot of patients of mucormycosis, and this is a dreaded disease. It starts from the rhino, orbital, and cerebral mucormycosis. And the first symptom is the numbness over the face, or loss of smell, headache, and then gradually loosening of the teeth. Then it gradually goes to the vision loss, and sometimes into the brain, and it causes death. So many of young patients we have lost, and early diagnosis, debridement of the patient, early debridement of the patient, followed by the antifungal therapy in the form of the injectable amphotericin B, posaconazole, isavuconazole is help, and still, till date, we are getting new patients of mucormycosis as far as the ENT is concerned.
Yeah, I think I agree with you. Dr. Sandeep, you wanted to say something.
I just wanted to have your opinion. Do you see any hearing loss as well? Because many patients have complained that after COVID, the acuity of hearing has been decreased.
So it is not related directly to the ear blockage. What happened actually, the patient during the COVID time, as of any other viral infections, have the sudden sensory neural hearing loss. But because the doctor was not available, hospitals was not open, and then this condition goes unrecognized, and patient was not diagnosed in the time, and so active treatment in the form of the steroids, in the form of the antiviral drugs, in the form of the hyperbaric oxygen therapy could not be given, and the hearing ultimately goes on toss.
Yeah, I have a question for Dr. Suryakant. A lot of patients had a lot of fibrosis. One thing you should remember, this is a regressive disease. Like people who were discharged on oxygen, slowly they came off oxygen because the normal lung remodeled, and they were off oxygen, first at rest, and then slowly over a period of few months, they were off oxygen. What is the question to you is, what is the role of this Perfinex and 9-antidanib? Although there is literature is very silent and not proven. So what is your opinion and what is the advice?
First of all, Dr. Rajesh Chabla, there is no clear-cut guidelines, either in our country or internationally, for the use of pirfenidone or nintedanib. We have also published a consensus statement in the Indian Journal of Chest Disease and Allied Sciences. If you go, that is the post-pulmonary, post-COVID pulmonary sequelae. And in that also we have said that there is a individual case reports or some individual observations which have come up. But this is my personal recommendation, that you should not be in hurry in using pirfenidone and nintedanib. Basically, post-COVID pulmonary fibrosis is not idiopathic pulmonary fibrosis. People get confused that, and they are started treating like a idiopathic pulmonary fibrosis. It's not a idiopathic pulmonary fibrosis. And with the lapse of time, there is a lot of improvement, as you rightly mentioned. So have a wait and watch. In certain subset of patients, you can use pirfenidone or nintedanib, depending upon the situation, but don't be in a hurry.
You know, the next question is to Dr. Yash Javeri. You know, a lot of patients have come with opportunistic infections. See, like one Dr. Alok mentioned about the mucormycosis. A lot of patients came with CMV infection, the galactomannan being positive, and the new terminology has come, COVID-associated aspergillus disease. So what is your experience on the CMV and the fungal infections and the other PCP and other infections?
Thank you, sir. The risk of hospital-acquired infection, especially in immunocompromised host, depends on many factors. One is duration of hospitalization. Second is degree of immune suppression. And third is exposure from the healthcare facilities. And probably we had household during COVID. Steroids were used indiscriminately for a longer while, which caused immunosuppression. There are many theories where COVID-induced immunosuppression, we are talking about, as we talked about, post-viral immunosuppression. Many drugs, antifibrotics, also cause some degree of immunosuppression, lymphopenia, various lineages of TLC were low. Those were also adding on to risk of immunosuppression. Added on, our infection control practices during the first wave were excellent, but second wave, most of the centers, they were not at par. So the risk was much more. And especially if we talk about pulmonary infections, we always kept a differential of CMV, PCP, TB also, because everything was being labeled as COVID, and we had everything there. So instead of labeling everything as COVID, especially in patients who have coming late or patients who have been transferred from some other setups, we have to be vigilant on diagnosis of infections such as COVID-associated pulmonary aspergillosis, secondary bacterial pneumonias, CMV. We had a patient of CMV pneumonia also during the course. So it was not common, but again, it was not rare also.
Yeah, because, you know, when patient is admitted in the critical care and is in the hospital for almost 1.5 months, and if he is not responding, all these should be tested, because we've seen all these cases and many of them on the specific treatment, they responded. And these 4 or 5 kind of opportunistic infections are very common. So before I wind up, anybody wants to say anything? Anybody from the audience wants to? Yes, sir. Can somebody give him the mic? Because the Dr. K.K. Agarwal wanted to teach, so anybody wants to teach is most welcome. Yeah.
I think I'm the most unique case because I had 3 times I had COVID. Once I had asymptomatic, and my case is presented in Frontiers of Medicine. In August, I had asymptomatic. I was going to travel last year August. I was going to travel, so I got my RT-PCR done. It was positive. I didn't have any symptoms. Then I got my vaccination, beginning of Feb, and then 15th of March. And then 10th of April, I had severe abdominal pain and high fever. So next day I got my CRP done, and it was 100. And then I tested positive for on RT-PCR, and my CT value on the RT-PCR was 34.5. And the stomach pain continued. I started all the medications. Dr. KK thought it was probably a thromboembolic complication of the vaccine. And so he started me on blood thinners and steroids. I took the steroids for 10 days. I had severe weakness, but suddenly on the 22nd, I was like magically okay, and my CRP had come down. So I started feeling all right. Dr. KK started fever on 26th, and he tested positive on 27th of April. And we admitted him to the hospital on the 1st. First and second, I was with him in the hospital. Third, I had high fever, so I didn't go to see him. And my RT-PCR was positive. My CT value was 18. My between the two episodes, 2 of my RT-PCRs were negative. My chest CT was clear. When I repeated the chest CT, it was 3 on 25 pneumonia. And on the 10th, my CRP was 250, on the 10th of May, when Dr. KK was already admitted. So I was rushed to the hospital, and I was there in the ward. All my inflammatory markers were very high. My CT chest showed 14 on 25. So I was there for 5 days, got the entire treatment and all. I got my genome studies done. So I had my samples from the previous April episode, and then I had my other sample from the May episode, and I did KK sample also. And so the first April episode was a UK strain, and the May strain, both KKs and me, was Delta variant. So
You are scaring us, because if you had with one strain and you got another strain, there could be problem. I think there are a lot of things still we don't know about this disease, and the recurrence is very, very rare. Even if you have infection with one strain, it does protect you from the other strain. Not completely, but does.
It was an immune escape, as is well known with Delta. So my case report is published in Frontiers of Medicine. And I think I'm the only person who's a documented reinfection, breakthrough infections. Because nobody has access, they don't have it so quickly within a span of 5 days. I guess because I had the things, I could document it. And what I wanted to know
You were symptomatic at all 3 times, right?
First time I wasn't symptomatic, but second UK strain and the Delta strain, I was symptomatic. Delta strain, I was in a very bad shape.
Can I comment?
Yes.
Rajesh, can I?
Yes, please.
So what is being touted is there is persistent viremia. You never clear. If the same strain occurred again, so you are not clearing it forever. So the moment it is a play between, so there is a theory going on that some people may be having persistent, non-manifest, like we have in herpes zoster. So the virus persists and whenever patient gets single. So similarly, even tuberculosis is a reactivation of existing tuberculosis. So as he says, we don't know the final answer, but that is one of the theories.
The genome studies and the clades, how typically they have a microbiologist say that there is a difference in clades, and there were 2 negatives in between. So it was all proven that it is a new strain. It was a Delta strain. It was an immune escape. So that's a short proven case. That's why it's got published also. My question was, I do have brain fog by the evening, but I pushed myself because I had no choice. I had a lot of work, thrown at me. So I pushed myself physically and mentally. So I don't have, thankfully enough, I don't have too much of long COVID symptoms right now, except for a little brain fog. Is there something I should be careful about? Is there, it's what, 3 months now?
I mean, there is nothing which can, the same precaution which everyone takes, you need to take that. That's the only thing. And I'm sure you must have been vaccinated as well.
I am twice, both my doses with Covishield. I was more than 40,000 post. They couldn't measure it.
Because you have a T cell immunity and this B cell immunity. What's your question? Anything very burning? Okay.
So thanks to Dr. K.K. Agarwal and thanks to Avis for wonderful unilateral teaching program today. Because we were not able to ask, but we learn a lot. My only comment is, this is a simple viral fever with unpredicted morbidity and mortality. When initially we had episodes of viral fever in our day-to-day practice, initially we are scared of the things and we take complications. Same is true with the COVID, first, second, third. So I just want to know from learned speakers, is there any clue to prediction of course of COVID in particular patients? What are the factors which will affect, like madam suffered and did not harm, husband suffered and succumbed to death. So what will be the predictable factors if we know?
It is still not known, but I think the genetics also and your immunity has some role. That's What so far it has not been really sorted out, although a lot of risk factors people have come out, predictors of mortality, but really to pinpoint like you are asking, it is still not. Anybody wants to say anything?
You are correct. Actually, so many risk factors has been laid down in various studies, right from obesity, presence of diabetes, presence of cardiovascular disease, so and so on, we can name. But still there are people like she has narrated her case, or even thin and lean people like Dr. KK, they have suffered badly. So still our knowledge is incomplete, and I personally believe it is principally the genetic constitution of the individual and the immunity, which is actually ultimately making the difference.
So I think with this, we are celebrating today a teacher and in his memory who used to teach, and this can go on, and because we have a limitation of time. So COVID, still we've not understood. A lot more to understand, lot more to learn from each other, and I think almost 50,000 papers have been published on COVID, and still simple answer question which she's asked we are not able to answer. And I think we need to continue our strive for learning so that we can help more. And with this, I thank all the panelists, all of you for your patient listening. Thank you very much. And hand over back to you.